Hello, I'm Dr. Marla Shapiro, and I'm a past president of the Menopause Society, and I'm joined today by Dr. Kutluk Oktay, who's going to talk to us about delaying menopause by ovarian tissue freezing and pharmacological means. He is a professor of obstetrics and gynecology and reproductive sciences, lab fertility preservation at Yale University School of Medicine, as well the associate editor of reproductive sciences, innovation for Institute for Fertility Preservation, where he's the medical director in New York City and New Haven, Connecticut. So first question I want to ask you is, what are the benefits of a late menopause?
Thank you for asking me, and thanks for the introduction. If you look at the studies on women who experience menopause late, that is after age 55, and that goes up to age 62. So women can naturally experience menopause as late as at the age of 62 years. Wow. There's a lower risk of osteoporosis, depression, cardiovascular diseases, diabetes, Alzheimer's, and retinal artery and vein occlusion. So there are multiple advantages that are associated with late menopause. And there are also studies that have shown that in parallel to age at menopause, the later you enter menopause, the longer you live. So we don't know the causality here, right? It could be that that genetic advantage that's allowing you to live longer, also making you go into menopause. But there is even an evidence that late menopause is associated with longevity.
Okay, so let's talk a little bit about ovarian tissue cryopreservation and transplantation. So how is that done to delay menopause? How does that work?
Right. So originally we developed ovarian freezing to help young cancer survivors preserve their fertility before sterilizing cancer treatments. And you remove ovarian tissue laparoscopically, and it's cryopreserved with a very specialized process involving cryoprotectants and methodology that has evolved over decades and still improving. And the ovarian cortex that contains all the primordial follicles is cryopreserved in little fragments in cryovials, and the patient is ready to have the tissue transplanted, ready to, in the original intent was fertility. Then we either laparoscopically or using robot-assisted surgery graft these tissues back. So once we saw the success with these medical indications, natural extension question came, and whether we could use this to delay natural menopause. And given that ovaries contain a great surplus of primordial follicles, women are born with 1 million eggs, and they only ovulate about 500 in a lifetime. Yet by menopause, it's all gone. The menopause happens because one runs out of primordial follicles. So if we can preserve these eggs before the ovary enters into this wasteful phase, usually after age 37 or so, at which time, because the egg quality is lower and the oocytes tend to die even faster, and then preserve them and use them at a later time, right before perimenopause, we hypothesize that this could actually delay menopause. And using existing medical information and the experience we gain from fertility preservation in cancer patients, and molecular data on follicular behavior at different ages, we've actually come up with a mathematical prediction formula, in which I'd be happy to discuss, predicted that in many women we could delay and possibly eliminate menopause by this procedure.
Okay, well, how do you select the patients for this procedure? And once you select them, what can they expect?
Right. So we actually use our mathematical formula for this, and which is on our website. called fertilitypreservation.org, and where our formula uses patient's age, the amount of tissue to be harvested, and estimated tissue survival. Now, with the older techniques, when you transplant during the healing process, during the ischemic phase, you're losing a larger percentage, but the techniques are improving. So we can vary that factor. And we've also, with this model, said, what about instead of transplanting all at once, we can fractionate it. And our model predicts that the more fractions you do, the larger stretch you get. So we use this tool, and which now goes up to age 43. We counsel our patients, and the formula also takes into account whether your ovarian reserve is at average, at 10 percentile, or below 10%, in the lower or higher 10 percentile. And based on that, we can have individualized predictions for patients, and the formula also spits out an ideal case scenario. It would say, well, it's probably ideal for you to take 50% of one ovary or 25% of your reserve and transplant them in 3 fractions, etc. And if your egg reserve is average or above average, you will get this much delay. And also, if you don't transplant it, you may experience menopause this much earlier, but formula gives you a net benefit. And previous studies have shown that even if you remove a whole ovary from a child, a 4-year-old, there are studies on average, you experience menopause 7 years earlier. And in adults, it's between 1 and 2 years earlier. So our formula predicts that you make more than, you make up that and more.
Yeah, so it's quite personalized. If we look on the other side, in terms of medical as opposed to surgical, are there any type of medical treatments or medical treatments in development that can delay menopause? What can we expect to see in this domain?
Right. So in my research laboratory, we've been working for years on single follicle RNA sequencing to determine the molecular pathways that are involved in follicle growth in human ovary. Thanks to organ donors, we get a lot of healthy ovarian tissue. And we have found a pathway and receptors, and which we can manipulate now, at least in human tissue, in human in vitro models or human ovarian xenograft models. And we can slow down, even accelerate if you wanted to. For example, if you want in vitro growth of follicles from Petri dish in vitro, now we're able to grow eggs from ovarian tissue. The opposite, we can turn it off and follicle loss is slowed down. So this medication, actually, there are drugs that act on these receptors and they're FDA approved. And potentially we're considering trials with these. And there is another trial going on at another institute with a drug called rapamycin. And it has a broader effect, these drugs, so we'll yet to see. But I think, the future will involve combination of strategies to address menopause, especially, the patients that I see, a lot of them have family history. For example, I've seen a couple of patients in the last few days. Their mothers experienced enormous issues during menopause, most severe hot flashes, mood changes, osteoporosis. It runs in the family. So a lot of young people who are concerned about these now are looking into these strategies. And so there's a selection within a selection process.
Oh, so fascinating. Well, thank you so much for joining us today. More to follow. You can see sort of the implications as we go future forward. Maybe menopause will be something that we can actually delay and, I hate to say banish, but certainly interesting. Thanks so much.
Why not? Yes.